those of you that have been here right from the start. We're on the final stretch. In this segment, we take a slightly different tack and we imagine what things would be like if at some point during our patient journey things hadn't gone as hoped. Despite the best efforts and intentions of our team, our patient has suffered an adverse outcome. In this segment, we want to consider the value of team debriefs following high-stakes events and high-stakes airway events and critical incidents. We also think about the changing culture in medicine as a whole around management of wellbeing around traumatic events. And we're going to think about what the attributes of an organisation that deals with the psychological and emotional impacts of critical events effectively. During this segment, we're going to watch an interview with a very experienced airway practitioner who encountered an adverse event and was part of a structured post-event debrief. Just a warning to our viewers that this segment will consider issues that may be triggering or upsetting for some. Post-event debriefs are advocated by many, but infrequently practiced due to both logistical challenges and controversies associated with critical incident debriefing. Before we start this session, I invite you as our viewers to take part in a poll. The QR code for this poll will be displayed on the screen. The question we're considering is, ideally, should a team debrief occur after all serious adverse airway events? If the QR code doesn't work, you can see the URL down the bottom. We'll come back in a few minutes to find the results of that poll. So, as I mentioned, formal post-event debriefs are a bit controversial, but I feel like ICU and probably ED are a long way ahead of anaesthesia in addressing traumatic events. Maybe because this cohort of clinicians, staff, deal with a lot of emotional stressors on a regular basis. Elliot, how does this constant exposure to emotionally challenging situations impact you and your colleagues, and what strategies do you have or have you seen others employ that helps deal with this?
Thanks, Adam. Look, I think you're certainly right in saying that seeing sort of, fairly emotionally sort of evocative things and dealing with tragedy and things on a regular basis definitely has a sort of cumulative effect. I think it affects one of the most important things I think is that it affects everybody differently, but it generally does tend to affect most people. So some of the things that I know certainly help me and my colleagues is the opportunity to talk about it with one another. But certainly in our unit, we do value the role of, debriefing after whether it's a particular adverse event or whether it's talking as a group about a particularly challenging patient or somebody maybe who has passed away at the end of a long critical illness. I think, my experience and especially having just gone through, COVID and our sort of second wave, if you like, here in New South Wales, we've had a good opportunity to sort of reflect on this. And in fact, just the other day, I had the opportunity to sit in on one of these sorts of discussions. And so I think the opportunity to be able to have some facilitated discussion after particularly sort of technically challenging or sort of the pointy end, if you like, adverse events associated with a procedure is very useful. But also, adopting a similar approach of people being able to come together as a group and reflect on maybe a patient's journey that hasn't ultimately ended up in them surviving or where there's been an outcome that people have found really challenging to process. And I think, we do it in our unit because we've been doing it for a while and we've got the opportunity to develop that locally. But, I think it builds on what sort of happens naturally, which is that people do tend to sort of talk about it anyway. And so bringing it to the fore and having it as part of the way that you address these types of incidents or these types of patients really is very helpful, I think.
So essentially you're saying that creating an environment or forum where people are comfortable talking about how they're feeling is a big component of dealing with this effectively.
Yeah, absolutely. Yeah.
All right, Sheila, I've got a question for you. Anesthesia rightfully is proud of their safety record, but what comes with this safety record is encountering bad outcomes very infrequently. Do you think anaesthetists and anaesthetic teams, because of this infrequent exposure to bad outcomes, are set up for a big fall psychologically and emotionally when we do encounter a nasty case?
And I think this is extremely important because when you have an adverse event, I mean, you're thinking about the patient, but you have to do, and Elliot has very beautifully talked about the team briefing, debriefing. I think this is very important. As a group, there has to be this culture in the department where you have to sit together and discuss where we failed together, and there shouldn't be any blaming. It shouldn't be about one individual. But I would also like to go ahead and say that you have to take care of the individual who's been involved with that event, because these things can affect people. It's variable the way people take this. So some people express themselves, some people don't and are quiet, and you have to be sure that the individual who was involved with this is safe and fine. You have to follow them up because the focus is often on the patient and the event and the team briefing, but we often fail to take care of the individual who was involved with the event. And we had a loss of a anesthetist who was very disturbed with the adverse event and had some serious consequences. So the thing is, I would say that teams should follow up on these individuals, talk to them over the next couple of days, because there's often tremendous sense of guilt and a feeling of uselessness of what you did resulted in an adverse event. So I think taking care of the staff and the individual is extremely important, and the setup should have a culture to have easy communication within the team.
Fantastic. And that you really touched upon that same idea that Elliot talked about, that each person reacts a bit differently, and you've just got to be prepared to allow them to react that way, but don't be afraid to have that conversation.
Yeah.
So to set the scene for this video, we're about to watch a video where I conducted an interview with a person that is undoubtedly the go-to airway person of our hospital in our area. This Chris, who you're going to hear, not only did he train with some of the pioneers of awake intubation in Australia, but that he spent 3 years in a small hospital on a Pacific island with little more than ketamine, lignocaine and a fibre optic scope to deal with a dizzying array of airway pathologies. Since then, he's regularly dragged out of bed to help all of us with difficult intubations and extubations on a regular basis, and people from hospitals far and wide consult with this guy. The case involved a woman with a horrible set of circumstances. She had a severe fixed neck flexion deformity with multiple previous neck surgeries, extremely narrow glottis and subglottis, poor respiratory reserve. Chris was called to help with this case. He successfully intubated her awake for her spine surgery, but then through a combination of circumstances, including a small flexible tube through the nose and a shorter than expected spine surgery, it was decided that she should be extubated in theatre rather than have ICU deal with a really horrible nasal tube that was never going to stay patent for very long. Despite using an exchange catheter, she seemed to be thriving. The exchange catheter was removed. She then obstructed and was rescued. There was a failed front of neck access by anaesthetist, both scalpel and cannula, and then in the end a surgical airway was performed by surgeons. Fortunately, some oxygenation was possible from above. Chris and the team were terribly shaken by this case, and we chose to conduct both immediate and delayed debriefs. The decision to do this debriefing in our centre was not taken lightly, and it is a controversial and fraught process. I was interested to hear how someone as experienced as Chris felt about this adverse event and how he felt about the debriefing process. It was a bit of an honour for me to do this because not only is Chris an experienced airway clinician, but he was recognised this year by the College of Anaesthetists in Australia with the Ray Hayter Award for a career of excellent pastoral care. And he has been the one in our department that would ring every anaesthetist after an adverse event just to see how they were going on the weekend. So to be able to offer something back to him was a bit of an honour to me. So let's watch this interview. Chris, thanks so much for joining me here. In a moment, I'm going to get you to walk us through a really difficult case that culminated in an emergency surgical airway. And I think it's important to add, this woman was decannulated a week or so later, had a good outcome.
Correct.
That said, I can still see how visibly shaken you are by this case, and I have no doubt, on the day, I don't think I'd ever seen you as visibly shaken, and the other team members were in quite a bad state.
Yes.
And so the point to be made here is, we very rarely focus on the psychological and emotional impacts of these unexpected outcomes. And to hear it from someone like you that's managed so many cases and had so much experience, I think it's really powerful. So how were you feeling on the day when this case evolved as it did?
So anaesthetics is different to surgery. In surgery, you cure some people and they have some bad outcomes, and I think they balance the two up and say it's okay. Anaesthetics, we can't really cure people. It's very rare. We can only harm people, and it's really, and we, being perfectionists as we are, it's devastating when you think you've harmed someone, in particular hypoxic brain damage. And I felt terrible, and I was having really evil thoughts about myself while I was holding the mask on and doing the face mask ventilating. What a dreadful person I was. But then, of course, the other parts of your brain start to kick in, and you realise you've done many more good things in your career than bad things, and that you just have to use your common sense and overcome the initial emotion and carry on and deal with the next problem and slowly start to heal.
So you've, over a career of doing a lot of good and reflecting a lot, have probably got a fair bit of resilience. But despite that, historically, what's your experience been with how anaesthesia medicine as a whole has invited us to deal with these events in the past?
In the 80s, when I trained, there was none of this support, virtually none. There was a couple of good people. A lot of the other guys would just swear at you, tell you you're hopeless, use some rude words and just walk away. And there was one devastating case that I wasn't involved in. I was the first year, and the second year had a devastating airway problem with the consultant in the room, the two of them together, and the patient succumbed to age 25. The consultant said, "This is your fault, you sort it out, I'm going home." And that's the last time we spoke to him about it. My initial reaction was that I thought this young fellow, who I liked very much, was going to kill himself. That was what I was thinking in 1984. But he didn't. And I think the main reason he didn't was because of Neil Street from the Children's Hospital, who was a third-year registrar. And he took this guy under his wing. He was all over him. He fussed over him. He talked to him. He rang him numerous times. All those sort of things came naturally to Neil. That it didn't come naturally to a lot of other people. I learned a lot from Neil that day, and I'm a slow learner, but I eventually learned more about how to think about things from other people's point of view. So just learnt from them, and eventually, if you never criticise people and try and be supportive, they will come and tell you the most remarkable things. On rare occasions, people have come and said the most devastating things to me, where they were thinking about killing themselves after a disaster. 4 times, in fact, in the last 25 years. And I'm pleased to say not one of them did.
So I think your experience has been, a lot of us have had that same experience, that a precious few along our journey have had the insight, deconstruct these events and allow us to be okay with how we're feeling with it, to work our way through it. And I think that's probably what, on a macro level in anaesthesia, but also within our department, has led to sort of development of welfare SIGs and this approach now to dealing with these events in a more formalised way. So, in fact, we approached this event in that way. How was that experience for you?
It's the first time I'd really been involved in one of these, and I was thrilled. I thought it was fantastic. In the room, there were 3 people from the welfare group there. They're all so kind, and I could see them controlling the room, but gently letting everyone speak, inviting people to speak, starting from the nurses, the scrub nurses, the anaesthetic nurses, the registrar, and working upwards. And I thought it was fantastic. And there's more. I mean, not only was it on that day, but the next day, 2 people rang and asked me how I was and how I was getting on and what my plans were. And then a week later, we had another session where we got together and talked about it all, and a little bit more factual that time about some of the timings and whatever. And I was honoured to be part of such a process, and I think it is such an advance on what we were doing in the 80s and the 90s and even the 2000s, and I am a great fan of it in every way.
What are your sort of tips for those of us who have had less experience to help us get through these type of events?
Well, there's the emotional side that it's part of medicine, that we try to help people, but there will always people that will do badly, especially at a big teaching hospital like this, and we just have to accept that, and should accept that we're in a high-risk job. We're trying to help people with terrible illnesses, and there will be problems, and that's normal. Secondly, the underlying assumption should be that everyone caring for the patient's doing their best, and then finally cultivate friends and loved ones away from work that you can talk to honestly about and say, something horrible happened at work today and I need to talk about it, even if you don't understand the anaesthetic details. This has been terrible and I'm really upset. And honesty is the best policy by a mile. To build yourself a wall from your loved ones and your friends in these circumstances is the worst thing you can do.
Fantastic. Chris, I really appreciate you taking the time to talk about this. It's clear that it's something that's really rattled you.
Yes.
And the reflection that you've done since, it's all been so invaluable for us. So thanks again for speaking to us.
It's a pleasure. Thank you for asking me to hear today.
Okay, so welcome back, and thanks panel for hanging around while we showed that video. That was a heavily edited and abbreviated version. A longer version will be available on our website or as a downloadable podcast for those that would like to hear more about that incident. Louise, what's your experience with post-event debriefing, and do you feel there's a role for it in terms of supporting the emotional well-being, or should it just be focused on learning, how can we be better clinical teams with this debriefing?
Yeah, look, Adam, I think in anaesthesia, we've learned a lot from our critical care colleagues, and really until a couple of years ago, we probably didn't have as good a process as we needed. And our current process is quite a bit like what Chris was describing. It's essentially a two-part process where we have an immediate debrief within 24 hours after the event. And that's really an opportunity to get a bit of a combined understanding about what's occurred. And our experience has been that if you go sort of too long without really understanding what's happened, it can have an unnecessary impact on those involved. That's normally quite informal, that sort of first debrief, usually with close colleagues, with mentors. If it's an airway incident, it would almost certainly involve the airway lead within our department. Kind of more of a technical debrief, if you like. And then we organise a second subsequent debrief. That's facilitated by an independent professional, usually at about the 3 to 7 day mark after the event. We have a lead within our department who organises this on behalf of any events that occur in the operating room. So we don't need to reinvent the wheel every time. The reason it's at sort of a delayed time is that it's really important we feel that everyone is there. So it often just takes that time to get everyone, be able to attend. One really interesting thing that we've learned over the years is that the people that you least expect to be affected often are. And if we sort of think about, an anaesthetic specific or an airway incident, it might be the theatre technician or the scrub nurse who's incredibly upset, who might think that they've done something or they've been involved in some way. And it's not until this formal debrief that we first really become aware of that. So come back to your question as to, is this a learning tool or is this an emotional support tool? I've certainly had the experience, and I'm sure others have too, that you've had, a case that was so traumatic that you can't even think about it. If you can't think about it, you can't learn from it. So I think if the debrief is successful, then it allows you to learn from, what has otherwise been a really traumatic case.
I think Sheila used the word a culture of support before, and I think that a debrief alone is not going to work unless it's embedded in a culture, in an emotionally supportive culture. Elliot, what happens in your unit after a serious adverse event, and what makes them work or not work?
We've got a reasonable amount of, I suppose, in-house experience with with debriefing, and some of that stems from other areas of practice around simulation and those sorts of areas. But we tend to have a model where there's a hot debrief, sort of immediately or within that sort of first 24 hours after something like this has happened, which as we just heard, really is about trying to just sort of get all of the facts together. And it also, I think, though, helps to identify anybody who is obviously not okay, right from the outset. And as time goes on, people tend to develop different responses to it, and so people who are okay at the beginning or sort of in the immediate aftermath may not be further down the line. And really, depending on the type of event that's happened, then there may be a second debrief, which is always really focused on making sure that everybody who is involved is present, and that some of the not just the technical learnings, but also some of the wellbeing aspects can be drawn out. I think that as far as the use of debrief, we're very conscious to make sure that people don't feel compelled to have to go and do a debrief straight away, especially if all of the right elements and circumstances aren't in place. And I think that's one of the pitfalls with debriefing, is if you start to feel as though it's just part of the process that happens, that you're expected to do straight after an event like this occurs, but you're not the best person to do it, or the best person to help facilitate those sorts of discussions isn't available, then I think we've sort of developed a bit of an understanding that that might not always be the best approach, and that holding off until you can have the right people there to facilitate that sort of a discussion generally tends to be the approach now. But I think it's just one of the traps you can fall into, which is feeling as though you're aware that debriefing is important and should happen, and feeling like there's sort of something missing after one of those sorts of adverse events happens, and feeling rushed into doing it. And so I suppose one of the things that we probably, I hope, are doing well here is trying to make sure that whilst it's a focus after there's something like this that happens, that it's done well and done in a way that everybody can be safe and learn from, rather than feeling like something that just has to happen, with some sort of rush after the event.
So I think your sense there is supported by the literature, which is that a debrief done badly is worse than no debrief at all, and the idea that just do something may not necessarily be the solution here. Now, in the operating theatre, it's easy to just say, right, we're not going to start the next case, let's quarantine the team, let's have a chat. But John, in a busy ED, it's not always that easy to just say, hey, close the doors, turn the ambulances away, we're going to have a chat about it. How do you guys deal with these situations in your place of work?
Right. That's really a unique situation for us because there's really, like you say, no downtime. You might have a death or bad event, and all of a sudden someone with a gunshot wound in the chest comes in, or a stroke or something. So it's really hard to do. What we try to do on all deaths that occur in the emergency department is, one, immediately after the death, we have a moment of silence for the person, because even though we may have not known them, they're someone's loved ones, they're someone's child, someone's grandparent, someone's brother or sister, whatever. So we hold a moment of silence. And then after that, we try to all just get together, even for 5 or 10 minutes, and sit down and get a bunch of chairs in a circle and just do a quick debrief. And everyone in the room gets to go around and just comment about whatever they feel like: a medical issue, things were done well, things were done poorly, things that we can do to enhance care in the future. And we just go around, and it takes just a few minutes, really, just for everyone to get something off their chest about what happened during that resuscitation.
And I think that really is supported by this increasing recognition that post-traumatic stress and similar things are a cumulative effect of lots of little ones. And if we don't acknowledge and punctuate things that happen to us, it will get acknowledged or punctuated by our psyche or our subconscious in a less helpful way. So that sounds like a really sensible approach to this. Before we go to any viewer questions, Sheila, I'm interested on any final thoughts on how we should be supporting individuals and teams after serious airway events, beyond what our panel may have already said.
I think the panelists have brought out very important points, and I would like to say that sometimes a formal debrief may happen a little later. But what's very important is to communicate with your team immediately after the event and the individual that was involved, and make sure they are well supported. Supporting them, talking to them. Sometimes they may not be comfortable talking to you. So whoever it is, their friends or whoever can talk to them, make sure they don't go home alone. Make sure there's friends and family to support them. And this is even more difficult when the event happens to a very senior member of the team, because if it's junior staff, you are there to support them. But what happens if this is the chair or somebody who's senior with whom this event happens? So whoever the individual is, you have to make sure that they are well supported immediately after the event. And we get busy with our lives and we forget to follow up on this. The follow up is also very important. And sometimes these individuals may need professional help. They may need psychological support. We shouldn't just think that we've talked to them and communicated with them and they've gone home and they have their families and they're fine. So I think this is something that, especially in the anesthesia department, that happens very rarely. But we have to be well prepared, and as I mentioned, have this culture of open communication and develop this kind of culture in our department. So
Yeah.
I've had one or two incidences where we've needed to provide psychological support to these individuals, and we never thought of that in the beginning. But following up on this is very essential.
That's a great point. The debriefing is just part of a culture of support, but it is not psychotherapy or therapy of any type. And when people need that, it's a tool to help identify and refer, but it's not a solution. So that's a really important point. I'm keen to see our poll results at this stage. So let's have a look at what. Well, I think all our nays have now just I can't quite read that.
Our one naysayer has logged off.
There's a so just Nick, I can't see from this screen. Tell us what the results show there. It's everyone in favour.
That is 100% in favour.
Okay, all right.
Only 29 people though.
Right. Well, still, I think it shows that there's a real will to do this. But hopefully, the lessons our panel have brought out that that not all debriefing is created equal, and that we really need to ensure that we're doing it very well is important. Do we have any questions from the panel at this point?
Yeah, just
not panel, from viewers.
Audience, just one question. Sheila was mentioning before about going broader than the debrief, and someone's asked, if you're concerned about something, what are the issues surrounding potentially contacting their family and saying that they're coming home, this has happened at work? Is it something a department should be doing to touch base with a partner or a friend to say, maybe you need to be aware this has gone on, because they might not raise it?
If I may take that, yeah, sorry.
Sure, go Sheila.
Sure.
Yeah, I think this is very important, because we think our job ends when we've spoken to them, communicated with them, and we think we've supported them. I think it's very important to make sure they don't go home alone. It's very important to communicate their partners, family, whoever is they're going home to, and tell them about what has happened and what the situation is, because we don't know how this individual may react to this situation. So I think making sure they're well supported for the next couple of days and following up on this, and also getting them psychological support if required, or even having a psychologist just speak to them, especially when you have a devastating event in the operating room. I think this is very essential, and we may not be the right people to do this, so we should get professional to talk to them after the event.
Fantastic. Thanks, Sheila. I'm going to bring this segment to an end, and I know you could argue that finishing our whole patient journey with this sort of fairly serious look at adverse outcomes, we're not necessarily finishing on the exultant high that we may have been on earlier, but I do think it was the logical discussion to have at the end of this, and I think it's a topic that has been shied away from in most medical forums that I've been involved with, and I think it's really topical and timely because most departments and specialties are looking at this in a big way at the moment. So I really thank our group for sharing their thoughts around this. I'll just summarise that what we've learned from this discussion is that while debriefs with the express purpose of mitigating post-traumatic stress disorder risk are controversial, and the collective consensus seems to be that we shouldn't. They are controversial, but the collective consensus seems to be that we shouldn't shy away from getting teams together and encouraging them to be open about how the experience has impacted them. Beyond this psychological support, the learning from the events can be invaluable. Following up individuals after these events and just having a chat can lead to some extraordinary admissions and provide valuable opportunities to support people. And it's not always the primary airway operator that is the most heavily hit by this, and we need to consider entire teams. Conducting these debriefs can build and should be embedded in a culture of supportiveness that can have additional wellbeing benefits.